Okay, so let's look at the composition of air. Most of it is actually nitrogen, almost 80%, and about 21% is oxygen. Okay, so uh, we can supplement patients with more oxygen in a variety of different ways. Okay, so someone who comes in with a severe asthma attack and we notice that they're hypoxic or hypoxemic, or their O2 saturation is reduced with an O2 sat monitor, we can supplement them with oxygen. Or somebody with COPD and they come in with a flare-up of their COPD, which is typically more coughing, more sputum, more shortness of breath, and often their oxygen levels have dropped significantly. So they may need supplemental oxygen. So there's a number of ways of receiving supplemental oxygen. And typically the least invasive are what are called nasal cannula. So the prongs that fit into your nose. And they're a low flow system, right? And we try to keep the flow rates between 1 liter and 6 liters per minute in a nasal cannula system. They're the most comfortable too, right? There's no face mask around the patient, making them feel claustrophobic. At higher flow rates though, so the closer you get to 6 liters per minute, the higher the chance you're going to dry out the nose, right? Because most of them don't have humidified oxygen, they're just straight oxygen. So patients tend to get a dry nose, bleeding, epistaxis, which is nosebleeds, all from the oxygen that's being delivered through their nose. So it can definitely cause nasal discomfort. So sometimes we can humidify the oxygen they're receiving to prevent that from happening. So the next option that we can provide more oxygen is some form of a face mask, right? So we can apply a face mask. It's more claustrophobic because it's over the patient's mouth and nose, and typically you can provide higher flow rates, usually in the range of 5 to 10 liters per minute. Okay, but again, it's a difficult mask to wear for prolonged periods of time. Okay, and lastly, if we need higher concentrations of oxygen, we can put them on what's called a non-rebreather mask. So it's basically a mask, and beside the mask there's a reservoir that's filled with oxygen. So the tubing is coming from the wall. It's attaching to the face mask, but also there's a reservoir that's always filling with oxygen. So when they take a breath in, they're taking a breath not only from the oxygen coming from the wall, but also some of the reservoir oxygen is going in. So they tend to get higher concentrations of oxygen. And sometimes we can attach a what's called a Venturi valve to the mask, and this can deliver very predictable fixed concentrations of oxygen. Okay, so if you're thinking of what form of oxygen delivery can be used, it's typically nasal prongs, a simple face mask, and then we can go to a non-rebreather. Okay, now if someone is not able to oxygenate when they're on a non-rebreather and they're still hypoxic and they're still gasping for air because they have a pneumonia or COPD, then sometimes we have to progress to intubation, where we put them on a mechanical ventilator. Okay, so let's talk about lung mechanics of ventilation. So ventilation is the process of getting air from the outside world to the alveoli. Okay? So the inspiratory part of ventilation is an active process. The diaphragm contracts and goes down. The intercostal muscles contract between the ribs and cause the chest wall to expand. And because the lungs are attached to the inner part of the chest wall and the diaphragm with a thin saran wrap-like lining called the pleura, they expand with the chest wall and also go down with the diaphragm during inhalation. Okay, so and you can see in the image of inhalation that the chest wall is expanding outwards, the diaphragm is going down, and the lungs are going to expand with the diaphragm and the chest wall because it's attached to the inner parts of the chest wall and the diaphragm. So during that expansion, you actually have negative pressure within the lungs. So you suck air in because of the negative pressure you've generated by this expansion. So at the mouth, there's the pressure of the environment, and in your lung, there's a lower pressure because of the chest expansion and the diaphragm contracting. So that's an active process. Okay, what about expiration or exhalation? That's a passive process. The intercostal muscles in the diaphragm have contracted. Now they're going to relax when the lung is fully expanded. And the lungs don't want to be that expanded. They want to recoil back to their resting state, which is much, much smaller. So because the lungs want to recoil and the chest wall is now relaxing and the diaphragm has relaxed, so it'll just follow with the lungs, the recoil causes positive pressure within the lungs and there's exhalation. Okay, so exhalation is a passive process. The whole muscular system of the chest wall and diaphragm relaxes and the lung recoils to its resting natural state. Now, there's two processes that we're going to separate one from the other, but they're very interrelated. So ventilation is what we just spoke about. It's the process of getting air to the alveoli and ventilating air out of the alveoli during exhalation. What about oxygenation? Well, oxygenation is the process of oxygen crossing over through the alveolar membrane and into the capillaries of the bloodstream. Okay, so two different processes. So you need proper ventilation to get the air and the oxygen to the alveoli, and then you need properly functioning alveoli to get the oxygen from the alveoli into the capillaries of the bloodstream. Okay, so ventilation and oxygenation. So if we said that someone wasn't ventilating, what we're really saying is they're not breathing well. So they're having difficulty getting air to their alveoli. If we say someone isn't oxygenating well, what we're saying is the oxygen that's in the alveoli isn't getting across into the bloodstream. Okay, so they're interrelated, but they're a bit different. Okay, so let's look at the alveoli. Okay, and this is the only place where gas exchange occurs. And typically the gas exchange is oxygen going into the capillaries and CO2 leaving the capillaries going into the alveoli to be exhaled. Okay, so what do they look like? Well, let's look at the image in the middle, and they're tiny air sacs, right? They're minuscule, each one, and they're basically one cell thick, so very, very thin. And you can see that around the alveoli, there's macrophages that are part of the immune system. There's capillaries that are surrounding the alveoli, which are going to perform in the gas exchange, right? The O2 going into the capillaries and the CO2 leaving the capillaries to go into the alveoli, okay? And then you have surfactant secreting cells. And those cells we'll talk about release a bit of a fatty substance that lines the alveoli, and it decreases surface tension. So it makes it easier for the lungs to expand. Okay, so we'll come back to that. So the alveoli are tiny little air sacs, 1 cell thick, and they're surrounded by capillaries. Look at the image at the far left, how each alveoli is very surrounded by capillaries to maximize oxygenation and CO2 delivery into the alveoli. Okay, so let's talk about surfactant for a minute. So if you lacked surfactant, and this can occur, say in a premature delivery of an infant, one of the primary reasons we get so worried with premature deliveries is that surfactant hasn't had time to fully develop around the alveoli, and the surfactant, which is like an oily substance, it decreases surface tension, which allows the lungs to expand much more easily. So what happens if you're lacking surfactant is you become very, very short of breath because you can't expand your lungs. Okay, they're not compliant. So the little infant is gasping for air because they're lacking surfactant. Okay, so if you took a big breath right now, you'd notice how easily your lungs expand when you take a deep breath. And then when you let go of the breath and the air just comes out passively, no energy required, right? The lungs just recoil. Well, without surfactant, you can't expand your lungs properly, and often these little neonates end up on a ventilator because they just don't have the energy to expand their lungs. Okay. Surfactant also prevents the alveoli during exhalation from fully collapsing on themselves. Okay, so surfactant has an important role in making sure that the lungs are compliant, meaning they can expand well, and when they recoil, they don't fully recoil and cause alveolar collapse. Okay. Now on the previous slide we were talking about the differences of ventilation and oxygenation. So oxygenation takes place at the alveolar level, right? So these images are where oxygenation takes place. The process of oxygen delivery from the alveoli into the capillaries. And if we're talking about the opposite, CO2 delivery from the capillaries to the alveoli. Okay, so when we're talking about oxygen and carbon dioxide, we're actually talking about diffusion of gases. So let's look at the image on the right here. So we have a blood vessel and CO2 is leaving the bloodstream, the capillary, and it's diffusing across this little space called the interstitial space that's between the capillary and the alveoli. So this is an extremely short distance usually, right? So it shouldn't be difficult for carbon dioxide to go from a higher concentration, which is in the serum, and diffuse into the alveoli, which has a lower concentration. And the opposite is with oxygen. Oxygen during inhalation is at a higher concentration in the alveoli, and it diffuses across this normally very tiny membrane of the alveoli and the capillary and gets into the bloodstream. Okay, So anything that interrupts the distance and makes it wider between the alveoli and the capillary is going to disrupt the process of diffusion. Okay? So the first place that oxygen is dissolved into when it goes into the plasma is the plasma. And then the pressure of the oxygen in the plasma causes oxygen to go and into the red blood cells and bind to hemoglobin. Okay? So the pressure of oxygen in your bloodstream then forces oxygen to go and bind on to hemoglobin, which is the main way that oxygen is carried in the body. The vast majority of oxygen that you carry in your bloodstream is bound to hemoglobin in the red blood cells. Okay? And what happens in capillaries around the body when oxygen is being released to feed tissues all around the body is that oxygen leaves the plasma and diffuses into the tissues that then feed the cells in the area. So the partial pressure of oxygen reduces in the capillaries, which then leads the red blood cells to release the oxygen that they're holding on the hemoglobin to go into the plasma and then into the tissue. Okay, so really there's loads of oxygen on red blood cells typically. There's oxygen in serum, and when the serum oxygen diffuses into the tissue, the red blood cell hemoglobin oxygen then releases more oxygen into the plasma that then can go into the tissue. Okay, so there's always a partial pressure of oxygen in the plasma. So the PaO2 is really the partial pressure of oxygen that's now diffusing into tissues around the body. I'm going to give you an example of this process. So say somebody has a significant pneumonia and they can't exchange a lot of oxygen in their alveoli because there's so much pus and bacteria in their alveoli. So that means that the partial pressure of oxygen in the capillaries is going to be reduced because oxygen can't cross from the alveoli to the capillaries, and that's going to result in a reduced oxygen saturation of the hemoglobin. Okay, so the oxygen saturation of the hemoglobin is dependent on the partial pressure of oxygen in the bloodstream. Okay, so let's continue with diffusion and gas exchange at the alveolar capillary membrane, right? That very thin layer of where the alveoli come into close contact with capillaries to exchange gases. So oxygen saturation in your blood, when you put an oxygen saturation monitor on your on a patient's finger, is actually giving you a percentage of how much oxygen is bound to hemoglobin. So how much oxyhemoglobin is there? So if it says 98%, it means 98% of the hemoglobin has oxygen bound to it. Okay, fantastic. That's a good number. If it says 80%, it means 80% of the hemoglobin molecules have oxygen bound to them. That's a low number. That's not good, right? So the oxyhemoglobin, or the saturation of hemoglobin with oxygen molecules, depends on what the partial pressure is in the bloodstream that's forcing the oxygen onto the hemoglobin. So the body really can't use the oxygen until it comes off of the hemoglobin, goes into the plasma, and then from the plasma it goes to the tissues and from the tissues, it goes to the cells. Okay, so the PaO2 is kept normal by the oxygen reserves on the hemoglobin. Okay, so as the PaO2, the partial pressure of oxygen in the bloodstream, starts to drop, say at the tissues, because oxygen is leaving the capillaries and going into different tissues of the body to feed them with oxygen, the PaO2 will be maintained by the oxygen that's leaving the hemoglobin to keep the partial pressure normal in the bloodstream, right? So just think of the hemoglobin as the massive and main carrier of oxygen, but it has to go to oxygen in the bloodstream, so PaO2, before it can go to the tissues. Okay, carbon dioxide. Well, carbon dioxide is in the plasma, right? We have a partial pressure of CO2 in our bloodstream. And CO2 is a product of cellular metabolism, right? The Krebs cycle and the electron transport system. End products are CO2 and H2O. And CO2 diffuses in the opposite direction. So it will go onto hemoglobin, and in the lungs, it will diffuse into the bloodstream, and it will move across the alveolar capillary membrane and then get exhaled. Okay, so basically the opposite direction of where oxygen is going. Okay, so on the left, this image is showing you with the red arrow oxygen that's being pumped to the lungs. That's oxygen poor, right? It's coming back from the veins and being pumped to the lungs by the right ventricle, and it's going to diffuse CO2 from the capillaries into the alveoli, and it's going to take O2 in terms of diffusion from the alveoli to the plasma, and from the plasma onto hemoglobin molecules in the red blood cells. And then the blood is going to continue on to the left atrium. It's been oxygenated and also been cleared of CO2, but it's been reoxygenated, and it's going to be pumped back into the systemic circulation from the left side of the heart. Okay. So on the right image, you'll see that CO2 is actively leaving the capillaries in the lungs, and O2 is leaving the alveoli to go into the capillaries. CO2 happens to have a much higher diffusion ability than O2. It can cross the membrane much more easily. So all we would need to do to reduce someone's plasma CO2 level or serum CO2 level is make them breathe faster, right? And in actual fact, if you breathed fast right now and we could monitor your CO2, you would easily reduce your CO2 levels in your bloodstream. You wouldn't really increase your oxygen levels though, because your oxygen is basically, if you have healthy lungs, fully saturated on your hemoglobin. You likely have an O2 saturation of 98, 99, or 100%. Okay? So you can blow off more CO2 by breathing fast though. And that's going to make you dizzy, and you're going to get numbness in your fingers, and maybe some numbness around your lips. And that's what happens during a panic attack, right? People breathe faster and faster and faster, and they get numbness in their hands and numbness around their mouth.